I think I saw more penetrating trauma and gunshots on my first day on call in Miami than I did throughout 6 years of training in Canada. It was a big revelation, and Miami is a fast city and a busy city and a big city, and the amount of volume of trauma I saw there was incredible. In Miami, I found my attendings were so passionate and committed to individual patient care, but also to building systems of care that can care for populations. That really resonated with me too, the idea that you can go from caring for one patient to caring for entire populations in the same job. So there are these sort of strategic, clinical, technical elements to it, and then there are also these human side of it, and then there's also a population side. So that sort of diversity of experience in some ways I think keeps you inspired and maybe protects you a little bit from burning out. There are some ways to keep this life more sustainable, I think.
This is the Visible Voices podcast. I'm your host, Dr. Resa Lewis. Before we get started, here's a word about our book, Microskills.
Hi, I'm Dr. Adaira Landry.
And I'm Dr. Resa E. Lewis.
We're dropping in to tell you about our new book, Microskills, Small Actions, Big Impact, that's coming in 2024, published by HarperCollins.
We believe every goal, complicated task, and healthy habit can be broken down into simple, measurable, and tiny skills that can be easily practiced and learned by removing obstacles, overcoming assumptions, and maximizing your potential at work and in life.
Microskills is our gift to you. It's fun and efficient. Our promise is that if you buy this book on a Friday, you will be better at your job by Monday.
Watch this space for more information and how to pre-order soon. Hi, listeners. Thanks for joining. And today's conversation content is topical because President Joe Biden announced the creation of the first ever federal office of gun violence prevention. My two guests are trauma surgeons and friends. Friends with me, but they've become friends and they've known each other for years, that is. Dr. Elliott Haut is a vice chair of quality safety and service in the Department of Surgery at Johns Hopkins Medicine. He's a professor of surgery at Johns Hopkins and also the editor-in-chief of Trauma Surgery and Acute Care Open. From Elliott, I first learned about the Stop the Bleed campaign. So this campaign was initiated by a federal interagency working group convened by the National Security Council staff of the White House. The purpose of the campaign is to build national resilience by better preparing the public to save lives by raising awareness of basic actions to stop life-threatening bleeding following everyday emergencies and man-made and natural disasters. My second guest is Dr. Morad Hameed. He is a trauma surgeon and intensivist at VGH, Vancouver General Hospital. There, he's an associate professor of surgery at the University of British Columbia. Morad has clinical and research interests in trauma and acute care surgery, with a particular focus on trauma systems, SDOH, that's social determinants of health, organizational culture, and health IT, that's information technology. So, audience, we hear this phrase, social determinants of health, a lot. What do we mean by this? Well, these are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So this includes, for instance, economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context. So full disclosure, as I said, Elliott and Morad are friends. Elliott and I went to college together, then we went to medical school together. We've been in touch ever since. Morad and I met at the University of Miami, where he completed his trauma and acute care fellowships. I was an emergency medicine resident rotating on the trauma service in Miami, and Morad was my senior. And boy, did I learn a lot. So let's get to the conversation. So I want to start by talking a little bit about the chronic exposure that each of you have as trauma surgeons. I'm particularly interested in sort of the chronic long-term exposure to trauma in terms of traumatic situations in the emergency department, in the trauma resuscitation room, and specifically related to gun violence. So I'm going to ask each of you to reflect on that and personally how you feel that's affected you. Elliott, why don't you take it first, then Morad?
Sure. So I trained in West Philadelphia at the Trauma Center at Penn. I was there for medical school, residency, fellowship. So I was there for a pretty long time, and gun violence was, just the normal everyday life in West Philadelphia and at the Trauma Center at Penn. I then moved to Baltimore. I now work in East Baltimore at Johns Hopkins Hospital and Summit Bayview is our level 2 trauma center. And gun violence, we see it every day. I've been here for 19 years. I take in-house trauma call. I don't see someone shot every single day, but on average, when we take trauma call, I see someone shot every day. And it is an ongoing thing. And it sounds sad to think about it, but I'm just kind of used to it. I've been seeing it for 25 years. I haven't seen it change much. It fluctuates a little, but it's still there in and out every single day that I see it.
Morad, before you take it, I'm going to push back a little bit on that, Elliott, because it does have an effect. Like it just does. Have you felt that maybe in your body, in your sleep, in your stress level, in your fatigue, in your ability to tolerate and navigate things at home, where have you seen it appear?
It is real. It is a real effect. I think the physiologic effect of call, as I get older, call is harder and harder. I get home from call. I used to be able to kind of power through the next day, whether it's, writing a manuscript or having meetings or doing more clinical work or rounds. First of all, it's just physiologically, I can't do that anymore. I think a lot of places have switched away from a 24-hour call model because of the physiologic effects. I have personally noticed, I'm sure we can talk about it later, but I got a Whoop. We can talk all about the physiologic effects of call. There's a lot of new research on that topic, and I see it in myself. And I think I now go to bed earlier. I try to be more healthy. I try to eat healthier because I think the physiologic piece of working in trauma is a factor that I can't change as much, and the other things are potentially more modifiable.
Did you say Whoop?
Whoop, there it is. It's right here. I'm wearing my Whoop right now. I learned all about Whoop from a trauma surgeon I know named Jamie Coleman. She did a big study, and I was a study participant wearing my Whoop on trauma call. And it's really interesting. You can find out the physiologic impact of, hey, I went on a 2-hour bike ride, and this is how much physiologic impact it had on me. And they have a category in Whoop. It's called high stress work. And I've started tagging high stress work where I can see for, a 2-hour trauma resuscitation and operation, my heart rate's 140. So it's like my stress test. Like I don't need to go take a treadmill stress test. I just had it.
Wow.
The physiologic impact of that is real, and it measures your heart rate variability, sleep, the effects of overnight call on sleep, and all these other things. I mean, we could talk about that for days.
Yeah. We'll get back to Jamie Coleman's study because I actually had that tagged for today's discussion. But Morad, take the microphone. Tell us about you and your reflections on this chronic exposure to violence and traumatic situations.
Yeah, thanks, Resa. I'm Canadian, and I did my surgical training at the University of Alberta in Edmonton, which is pretty high volume surgical training. But I did my fellowship in trauma and critical care at the University of Miami. And I think I saw more penetrating trauma and gunshots on my first day on call in Miami than I did throughout 6 years of training in Canada. It was a big revelation. And Miami's a fast city and a busy city and a big city. And the amount of volume of trauma I saw there was incredible. I also really fell in love with sort of the strategic and technical side of trauma care. And you're asking about what type of toll this takes on us. And I think sometimes we kind of compartmentalize it. Elliott, I'm sure you agree too, is like you view an acute trauma situation or a multi-casualty situation as a technical exercise, and you try to excel at the technical and strategic aspects and bring your team through it gracefully. And sometimes you lose sight of the enormous tragedy that trauma represents. And that can maybe hit you later, a day or two later, or when you go out to talk to the families. In Miami, I found my attendings were so passionate and committed to individual patient care, but also to building systems of care that can care for populations. That really resonated with me too. The idea that you can go from caring for one patient to caring for entire populations in the same job. So there are these sort of strategic, clinical, technical elements to it. And then there are also these human side of it. And then there's also a population side. So that sort of diversity of experience in some ways, I think keeps you inspired and maybe protects you a little bit from burning out. When you feel like hope is lost after a busy night of trauma call, you can still try to work on the injury prevention side the next day, or try to build a better system that cares for patients better, or try to engage with patients and families to renew your energy from that type of interaction. There are some ways to keep this life more sustainable, I think.
If I can interject, so Elliott, you and I went to college together and med school together. Morad, you and I met in Miami when I went specifically to do a trauma surgery rotation because I hadn't had a lot of exposure in Boston. And as an emergency physician, I really wanted to get used to trauma resuscitations. And that month was a very important month in terms of training as a physician, in terms of meeting lifelong friends such as yourself, and also what you just shared about how to get through it or how you've navigated it. For listeners that are like, oh, doctors, we are supremely good at intellectualizing. We are supremely good at sublimating. And, we use our forces for good, not evil, like back at the Super Friends, back at the Hall of Justice. And so I think all that is real. And the way Elliott reflected about the Whoop, many friends are on hypertensive meds and they now have high blood pressure and they're not on just one, but they're on two or three. Or, perhaps our BMI has crept up or, whatever it is. But I think I want to touch a little bit on sleep and Jamie Coleman's study, because this study just came out, Annals of Surgery, in June of 2023, Surgeons' Sleep and Burnout Results of the Surgeon Performance Trial. And the conclusions of this study that Jamie did with many co-authors, and this was taken from population in the ACS, the American College of Surgery, lower quality and reduced amount of sleep compared to an age-matched population. The reduced sleep and decreased time since the last call, and they were talking about this concept of in-house call. And listeners, that means that basically you sleep in the hospital for call, led to increased feelings of daily burnout, accumulating in emotional exhaustion as measured by this certain scale. And in the paper is calling for a reevaluation of the requirements in terms of in-house call and ways to restore homeostatic wellness in the ACS, the surgeon community. So that's all to say that the way it's always been done may not be ultimately the healthiest way for all of us, for all of you. I'm not taking in-house call as a trauma surgeon to do. Morad, why don't you take sort of a reflection on, you're overseeing trainees and, you're caring for other faculty that essentially become family. And if someone's not doing well, everybody chips in. What are your thoughts on that?
Oh, there's so much there. First of all, the idea of family. I really feel that our colleagues and our residents and fellows and students are family. They become so close to us and we develop these very close friendships, and that is very sustaining, but it's important and it's a way to look out for each other. On the topic of sleep, Resa, I don't know, but I'm sure it's been the same for both of you, but it used to be a badge of honor to sleep less. Like, you only got 3 hours last night, or I only need 4 hours a night, or, you didn't feel like you'd accomplished enough unless you worked 18 hours. Like, I was very much in that mindset for much of my career. Then I started realizing that, a friend of mine is a sleep scientist and talked about the essential importance of sleeping 7 hours a night. And I realized that if you don't sleep that 6 or 7 hours a night, you actually are not your best self the next day for all the reasons that you said. And so you can go through life sort of in a haze, in a grumpy haze, or you can go through life with energy and cheerfulness and being a positive force in the world. And sometimes that just comes down to sleeping enough and prioritizing sleep. Like Elliott said, making sure you go to sleep on time instead of wasting that last couple of hours surfing the internet or something like that.
What about you, Elliott?
I've definitely changed my attitude of sleep. Like, when I was a resident, we worked really hard. This is kind of the transition to the 8-hour work week. I was working way more than that. And I felt like I had just kind of gotten used to it. And I would say over the past 5 to 10 years, I've realized, I didn't really get used to it. And I was kind of chronically tired. And I think this idea of, hey, there are still nights where I am up all night operating. And I think, Resa, whether you're an emergency medicine physician, whether you're an obstetrician delivering babies, whether you're in the intensive care unit, whether you're a trauma surgeon, there's still patients that need our care 24/7. So we cannot just say, oh, our practice is 9 to 5. We are not, I don't want to disparage dermatologists, but we're not dermatologists. So there's stuff that happens 24/7. That being said, we can come up with a way to staff hospitals with people that can do these things 24/7 without killing ourselves doing it. We as a profession are realizing that has to change. And places that have historically been like, oh, you just work 36 hours, you come in at 7 o'clock in the morning, you do some work, you round, you see patients, you operate all night, and then the next day you still have things to do till 5 o'clock. Those places are going away. I don't know that we're ever going to get to, 8-hour shifts in trauma surgery, but the concept of, just power through 36 hours is, I think, slowly changing in medicine. And it's hard to change, the way we've always done it.
I want to talk a little bit about the Stop the Bleed campaign. And recently in Philadelphia, there was a mass shooting. Last week in Baltimore, there was a big shooting. You've done a lot of work with Stop the Bleed. I'm wondering if you can tell the listeners about that and what role it plays in trauma and trauma resuscitation.
So Stop the Bleed is, I tell people, it's the analogous piece to what we've been doing with the American Heart Association teaching CPR. So the lay public has learned CPR. The lay public has been learning CPR for 25 years, probably, even longer, maybe. So people are out there taking basic CPR classes in the community to help someone who has a heart attack. Stop the Bleed is the analogous piece of what the lay public can do. This is not what a trauma surgeon can do, or an emergency medicine physician, or a paramedic. This is what the lay public, not medically trained, can do when someone's injured. And you kind of prefaced it with the gun violence piece. I want to dissociate it from gun violence because it's not just for gun violence. I don't want people to think that the only reason I need to learn this is for gun violence. We see people who have car crashes. I have a patient who is a strong patient advocate, Deborah Dobkin, who I worked with, and she helps teach about Stop the Bleed. She was run over by a dump truck and was saved by Stop the Bleed initiatives. And now she's a double amputee who's out there helping teach about it. So this is not just about gun violence. It's one piece of it, but it's not the only piece. So the idea is we go out into the community and teach frontline humans. We teach it to high school students. We teach it in churches, synagogues. We teach it at public safety at the mall, at casinos, at the airports, all these places, so that everybody can learn the techniques. And it's basic stuff. It's an easy 1-hour class. It's free. We teach it everywhere for free. And when I say we, I mean, myself, trauma surgeons, emergency medicine doctors, EMTs, paramedics, etc., teach it all around the world. You can find a local class. Go take the class for free. It's an hour of your time that is well worth it. It'll teach you techniques. It'll teach you skills. And then when we combine that with putting the equipment at the hands of the people who might need it, then that's kind of the whole package of Stop the Bleed. So right now, I walk around and look for the AEDs. These are the defibrillators that are stocked kind of everywhere. And many of those places now have equipment for Stop the Bleed right next to it.
Got it.
So that's kind of the overarching idea of what Stop the Bleed is.
Morad, I think the listeners are wondering the extent to which you see gun violence in Vancouver the way we see it in the United States, and what role does Stop the Bleed play in educational efforts in Canada?
Well, since coming back from Canada, I've seen a lot less gun violence than I did as a fellow training in Miami. But there still is gun violence. And in fact, Canada has the 5th highest rate of gun ownership among high-income countries and the 3rd highest rate of firearm homicide in high-income countries. So there is a problem, and it's rising. We think that the incidence of firearm-related injuries is going up. And so we do have Stop the Bleed here. We train our population here in Stop the Bleed. There have been mass shootings in Canada, I think something like 15 in the past decade. That's a lot less than 200 in the US alone this past year. But it does happen, and we expect it to happen, and we want to make sure that we're prepared. So Stop the Bleed has been useful, and we've all embraced it and trained in it. And Resa's an example of like a public health initiative that resulted from frontline experience with trauma. So that connection between this individual act of violence to a population-based approach to try to reduce that tragedy and that burden of injury, I think it came from the Sandy Hook Elementary School shooting in Connecticut. There was this Hartford consensus where all of these trauma care providers got together to say, what can we do to mitigate this effect of gun violence in the future? And I think that Stop the Bleed was sort of a wonderful result that came from that effort that could have broad impact on population health.
Yeah. I'm so appreciative to both of you for joining me in this conversation. And, another personal, professional question, what keeps you up at night? Morad, why don't you take it first, then Elliott?
Going back to the sleep issue, I usually don't have that much trouble falling asleep. But what does keep me up at night is probably thinking about the experience, the welfare, the future of our trainees for some of the reasons that we discussed. Will they have healthy, rewarding careers and a chance to fulfill their potential? I think the fulfillment of potential is a great responsibility that surgeons and physicians have to their trainees and to their patients and their patients' families. And so I think that's something that I think about a lot, is how do we create conditions for the people that we care about to fulfill their potential?
What about you, Elliott? What keeps you up at night?
It's interesting. There's so many things in medicine that we cannot prevent and we haven't figured out how to fix, and diseases that come up that we're trying to treat and everything like that. Those are kind of our baseline. But there's so many other things that if we as a society could improve, we would improve the health overall. I mean, the gun violence one is a perfect example. I don't know how to do it, but if you suddenly made it so nobody got shot, no intentional violence, no, and I don't like the term accidental firearm injury, because, little kids finding a gun that's unlocked and unsecured and unsafe is no accident. We can prevent that. So if we could prevent gun violence, drinking and driving, we fixed drinking and driving. Not really fixed it, but it's so much better than when I was a teenager.
Yeah.
We fixed seatbelts and cars are so much safer. Yes, people still die in car crashes, but it's so much better than it used to be. I mean, I see a huge part of my practice is trauma and emergency surgery. And if we could make the trauma stuff go away with injury prevention, gun violence prevention, impaired driving, all these other things. And then if we could stop, infections from drug use, we see a lot of other comorbidities related to smoking, other drugs, et cetera. Like if there was a way we could change people's attitudes and, what they do to take care of themselves, it would be an amazing thing.
Each of you have a voice, a visible voice. And I'm wondering if you can each take the time to share with the listeners, when did you realize you had this voice? When did you start using it? And you can define that however you wish, personally, professionally. Elliott, why don't you take it first, then Morad?
So it's a great question. I've been accused of being the guy who's somewhat controversial, not in the bad way, but like if there's some meeting, I'll be the one who raises my hand and I'll say something that a lot of other people are thinking. And afterwards, they'll come up to me and be like, Elliott, thanks so much for saying that. That was on my mind, et cetera. I'll be like, I have a question. And I'll just pose it as a question to the group. And I'm not the controversial person. I'm just the one who's asking this really hard question. Hey, why do we still work 36 hours? There's got to be a better way. Do we just have to do it because that's the way it's always been done? No. Like, these are the kinds of questions. I don't know when I got that, but I feel like I've always kind of been the one who just asked the hard question. I would never be accused of being, quote unquote, a yes man. Great. So that is never going to be me at all.
Beautiful. Morad?
I think being an attending surgeon kind of thrusts you into some positions of leadership where you have to have a voice and make decisions and represent your team. But I think I would say, Resa, I'm probably more of a fan of other people's voices. I get to work with some amazing people and get to learn from them and sort of see if I could be a microphone to project other people's voices. And that's been a great source of inspiration for me.
The Resa Wrap-Up. 3 things I learned from Morad and Elliott. Well, first of all, let me thank these 2 gents for joining me. I'm delighted. I wanted to bring them on around the topic of gun violence awareness, gun violence prevention, and the work of both of them, their commitment to patient safety as well as prevention of trauma, both personal trauma as well as trauma in our communities and in our nation, are just impressive. So first of all, stop the bleed. These campaigns, these free educational workshops, are given throughout the country. And so if you want more, take a look at the show notes on the website. Number 2, trauma. I really was trying to get to, with Morad and with Elliott, what they do to take care of themselves, because I think coming out of COVID, coming out of the recognition of the micro cuts, the microaggressions, and sort of the slow hits that we take as clinicians in the clinical environment, it's really important to call out and talk about mental health of physicians, as well as trauma treatment, trauma prevention for those providing care. And finally, I think both of them inspire me to continue to commit to the role of the voice of physicians. I think there is a role in society. There are privileges afforded physicians that we really just cannot be quiet. We need to stay steady and committed and make our voices visible. That's it for this week, audience. See you. The Visible Voices podcast amplifies voices both known and unknown, discussing topics of healthcare, equity, and current trends. We are a production of the People's Media Network. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Please find me on social media at Resa E. Lewis and through the website, thevisiblevoicespodcast.com. If you like the podcast, please rate and review us. Share the podcast with a friend today. Thank you so much for listening, and as always, to be continued.